Hello, I don't hear anybody. I don't hear a thing.
I don't either. No sound coming through.
I don't either.
No sound. We can't hear you.
Um, I heard you say I can't hear you.
Yeah, yeah, I'm Peter Gulick, so I'm the lecturer, but I can't hear Renee at all.
I can't hear anything at all.
I can't either.
Okay, good to know I'm not the only one.
I can't either. I sent a chat note to Renee. Hopefully she'll see it in the next few seconds.
Yeah, good point. Can everybody hear me okay?
Yes, I can hear you.
Wonderful. Let's see
Yes,
if
I can
Renee at
hear you.
least can change the slides for me because I can't change them, but she can change them. So, Renee, can you change the slide? Renee, can you change the slide? She seems to be hung up somehow. She doesn't have her reception's gone. Oh, all right. So let's see what we can do. So next slide, please. Okay, so we're going to talk about measles, and I'm going to give you a update on where we're at now and some of the background. So I'm going to give you an overview about the epidemiology, talk about the clinical presentation, and then about how to diagnose somebody, and then the provider's role in handling somebody that may be positive for measles, and then also talk about prevention, both pre and post exposure. Next slide. Okay, so this is as of May. We're right up to date. The only thing I'm going to change here is the total cases are 1,000, over 1,000 now, and the majority are still in Texas at 705. And so from what I've been reading, and it's a daily thing, is that the cases have not exploded, but there's still some coming out. But I want to give you an overall general view. And 30 states have basically declared cases of measles, including Michigan, where there's 7 cases currently. And one of and they're in Oakland, Kent, Macomb, Ingham County, and then Montcalm actually had like what they call an outbreak where there were 3 cases together. But you can see there the majority individuals under 5, about 30% of cases are seen in that group. Ages 5 to 19, 38%. Over 20 is 30%, and then age unknown 1%. But the majority of them, 96%, are either unvaccinated or unknown. But again, the majority are probably unvaccinated, with 2% having 1 MMR and 2% having 2 MMR doses. Next slide. Next slide. So the hospitalization rate initially was much higher, but as of right now, it's about 13% of cases being hospitalized. And you can see there again, the majority are in individuals under 5 years of age at 23%, and then the other 8% for the other 2 groups, and then 15% unknown. Death rate is 3 confirmed deaths at the present time. So right now, we're just dealing with outbreaks more than serious situations, but we still have to be very careful, when we're dealing with patients that are immunocompromised. So let's go over it just in general. And what I want to do is just take you back and give you a little bit of a history of measles. And prior to 1963, it was a worldwide issue, both epidemic and endemic. And individuals were, all children got measles by the time they were 15 years of age. And there were anywhere from 3 to 4 million cases annually. And you can see back in 1912, there was like 6,000 measles deaths that occurred each year. And in the decade before 1963, back in the 50s, or even earlier than that, there were about 400 to 500 people that died with it. And go back. 48,000 people were hospitalized, and then people did suffer from some of the consequences, which I'll talk about, including encephalitis. Next slide. So then in 1963, there was a vaccine that was introduced. You can see on the graph there on the right side. And then in 89, 2 doses of MMR, measles, mumps, rubella vaccine, was scheduled and was introduced. And then in 2000, measles was declared eliminated from the United States, meaning that there was an absence of any endemic cases or transmission. And you can see the graph there where we go beyond 2000, it was basically flat. Next slide. So then we carry it a little bit further. And so, because of the effective vaccine, this is what really made the whole difference as far as controlling measles. And since 2000, and you can see where we carry this a little bit further, there's been little outbreaks. You can see in 2014, there was a rather high spike, and then little spikes all along. But they were related to 2 major issues. One is international individuals came from other areas of the world where vaccines weren't done, or communities where poor vaccination rates were accomplished there. And remember, we need 95% vaccinations to prevent, to keep ourselves safe from outbreaks of measles. Next slide. And so this is an interesting virus. It's an RNA virus that's part of the family where we see respiratory syncytial virus, mumps, parainfluenza virus. They're all within the same family where measles. And the interesting thing about measles is the humans are the only natural host of measles, unlike other viruses where you could say COVID came from bats and other viruses came from other animals or different things. Measles is purely a human infection with the human as the natural host. Next slide. And so what you see with measles, because of that, you don't see this change in different serotypes and that, with like we see with COVID or like we see with influenza, where we get different strains all each year or whatever. It's the same strain. The vaccine works very effectively with this virus because we are the only natural host. And so the main illness of measles is that acutely, you get this rash that's kind of characteristic, starts in the head and the face and then moves down. And it's high and it's transmitted mainly through infectious droplets or airborne route. Yes, the slides will be available. And measles is very contagious, very contagious. 90% of individuals household contacts will develop the illness. And this RO1 means basically the number of people that are infected from one case. And so when I look at RO1, for instance, and I'm actually missing a slide. Could you go back one slide? Okay, yeah, this is where I think I messed up a little bit somehow. There was a slide, that was a slide I wanted to go over first. But yeah, it's very contagious, airborne route. It can live up to 2 hours in a space where a patient was sitting. So if you had an outbreak or if you had a patient in your clinic that you suspected had measles or did have measles and you had them in a room, you would keep that room isolated after that patient left for at least 2 hours, because somebody going immediately in that room after a patient with measles left could still get infected with the virus up to 2 hours after, in that airspace. So that's an important point to remember. And 90% of individuals close to that person who are not immune will also get infected. And we'll go over this in more detail, but the real times of infectivity are 4 days before and then 4 days after the rash appears. And I'll go over that again. Now go to the next slide. So this is a febrile rash transmitted by air droplets. So it's airborne, so it's respiratory transmitted, not transmitted through other mechanisms. And it's highly contagious. And where I was getting into that RO1, just to give you an example, one person can infect up to 18 people that are unvaccinated with measles. If you look at mumps, one person can infect 14 people if they had mumps, and then we'll go right down the line. Chickenpox, one person can infect 12, and then if we go into COVID-19, one person can infect 3 people, and then the Spanish flu 1 to 2. So you can see how measles, compared with other viruses, highly, highly transmissible, very transmissible to many patients. So that RO is a high number. Next slide. So the symptoms I want you to be aware of is the 3 C's. So these are the initial symptoms: cough, coryza, which is redness and swelling of the nasal mucosa, and conjunctivitis, where the eyes are red and watery. The other classic sign that you will see in a person with measles that's unique to measles is what they call Koplik spots. They're like little sand granules that are peppered in the back of your throat, on the cheek, and on the back of your throat. And they can look either bright red, they can look white or bluish. And I have a couple of pictures to show you of that. But that is pathognomonic of measles. And then you can also get malaise, anorexia, diarrhea, lymphadenopathy. Those are some of the initial signs of a presentation with measles. Next slide. And so the early signs are within the, first 4 days. You get that incubation period that can be anywhere from a week to say 3 weeks from the time of exposure to the time of symptoms. But the first symptoms, early symptoms, which can last anywhere from 2 to 4 days, is the fever, and then the 3 C's: the cough, the coryza, and the conjunctivitis, along with Koplik spots. After that, then the typical rash occurs. So you get the symptoms and then the rash. And the rash usually occurs about 4 days later, 4 days into the symptoms there, and it can last up to a week, if not a little longer. This rash starts on the head and the face, and then it moves down, and it's macular papular. It's not vesicular or pustular or anything like that, but it's macular papular, either flat lesions or little raised lesions. And they can go from the head and face to the trunk to the extremities, and then they fade. So they start fading in the head and the neck, and then they fade as they go down. The serious complications that I'll get into again are diarrhea, permanent ear infections that can lead toward permanent hearing loss, pneumonia, brain swelling, and even death. Next slide. So this is the characteristic timeline. So what I want you to focus on again is the the little blue line there is the incubation period. This means from the time you get exposed to it to the time symptoms occur, it can be anywhere from 7 days up to 21 days. And then what happens is that the early symptoms occur on -4 on the red now we're looking at, where you get the fever, the 3 Cs, etc. And those will last anywhere from 2 to 4 days. And then all of a sudden, then the rash will occur after that, which is a macular papular rash along the face, the neck, and then it spreads down to the trunk and the extremities. And during this red period, there is when you are very infectious. So when the symptoms start to develop, when the rash occurs, and then 4 days into the rash, then that's when you are the most infectious and where you can transmit it to a lot of people there. So it's pretty much like almost a week or a little bit over a week where you're highly infectious. During that incubation period, before any symptoms occur, you're not really that infectious. But during the other times there, definitely. And remember, it's respiratory spread. So that's the normal timeline. So I want you to be very, very much aware of how these symptoms occur. Next slide. And so these are just basic characteristics. You can see the young man at the top there has the rash on his cheek and the head and neck, and then it will progress down to the trunk. And you can see the child that's down below there with the little bar across his eyes. He's got that macular papular rash both on his trunk and on his extremities. And then you can see the same rash on the little child on the right side there. And then way on the right, you can see the one with the conjunctivitis, the redness in the eyes. You can't see it real well, but that's one of the things. The coryza, the stuffiness of the nose, the congestion, and the cough, along with the conjunctivitis. And then on the bottom, I hope you can see this, the Koplik spots. You look in the throat and on the buccal mucosa and on the back of the throat, you'll see these they look like little granular things, like somebody threw some sand in there, but they're white. They can be bluish and they can be red as well. And they're just little like granular salt type things. And hopefully you can see those. They're white at the back. Those are the classic pathognomonic finding that you're not going to see in other viral infections, but you're going to see it with measles. Now you might say, well, what does herpes do? Herpes has vesicular rashes. They have little vesicles with little shallow ulcers. These are not even close to that. So that's why Koplik spots can be very pathognomonic here. Next slide. So complications, this is where, again, you worry about, what can happen. It's not just a simple condition that might come and go, although the majority of it is, but you look at children younger than 5 years of age or adults over over 20 years of age are most likely to suffer from the complications of measles. And so the complications can be an acute otitis media, which occurs in about 10% of individuals. And this is the important thing, it can result in permanent hearing loss. So this is not just a minor otitis that comes and goes. It can result in a permanent hearing loss. Pneumonia can be very severe, 5% of the time, and children get it. And this is one of the highest risks for death in children with measles is pneumonia. And so this is another real serious complication that can occur with measles. Next slide. And then a condition called subacute sclerosing panencephalitis, big long term, and it's rare, but it can be fatal. And here's the serious thing about it. It may not occur immediately after or during your bout of measles, but it can come across 7 to 10 years after you've had the infection. So it can be very unpredictable, but very serious. And what this condition is basically a swelling of the brain with encephalitis that can cause death within 1 to 3 years after diagnosis. And it can be very, very serious. And within 3 years or 3 years, 3 months of symptoms, the death rate can increase. And it's the individuals that are at highest risk for this are the very young, the ones that are less than 2 years of age, which means that's why you want to make sure these young kids get vaccinated immediately if there's any sign of them exposed to measles or in any areas where there's outbreaks of measles, because this condition, although rare, can occur and it can be a real high morbidity mortality. And again, it's you can see there that the vaccination has caused a decline in this condition in countries that use the vaccine. And this is where it's important that children get the vaccine at a young age, and they should receive their first MMR, between the ages of 12 and 15 months. And sooner if they're going to go into an endemic area or an area where you're concerned about exposure to measles. Next slide. So what about the vaccination? It's the best way to prevent measles at all times, especially during an outbreak. And you can see there that one dose is 93% effective in preventing measles if exposed, and 2 doses are 97% effective. And again, just like any other vaccine, a person, about 3%, which is pretty low, even though they've gotten appropriately vaccinated, they may still get, measles. But the positive thing is that they more likely will have a milder illness and they are less contagious as far as spreading it to others. So complication rates as far as pneumonia and otitis and panencephalitis are much, much less, as well as their ability to spread. So even though a very small percent may not totally resolve and eliminate it, it still prevents the serious outcome and the transmissibility. Next slide. So what about the current outbreak? Where are we at? What is going on here? Next slide. So you can see here that, 2014, I showed you before there was a spike, and then 2019, and then we kind of, crossed, and this was mainly from international travel and individuals that just didn't get the vaccine locally, within the United States, and that those contributed to the major causes of those outbreaks that you see. Next slide. And then if we carry it from 2023 to 2024, we can see where now you see a cluster now as we go into December of 2023, January, March, and in May, where now we're seeing clusters where it's not a flat line anymore, and there's not just a spike here and there, but it's a continuous problem with more and more cases because of the problem of unvaccinated individuals contracting it and then spreading it to other individuals that are unvaccinated. Next slide. And so now we're looking at, characteristics of the reported cases from January 1st to May 2nd, but 1 year ago. And I'm going to give you a comparison with that when the N was 132 at that point. And now, as I told you before, it's over 1,000. And you can see there that as far as age groups go, back early on a year ago, the majority of cases were seen in individuals under 5, with 44% of the cases being there. Now, the under 5 is about 30%. And now if we move to 5 to 19 years of age, where we see 23% of cases, that incidence, so it's a much higher percent now at 38%. And then 20 plus years is 34%. And now that's gone down to 30%. So the major change has been that we're seeing more cases in the 5 to 19 years of age. As far as vaccination status, the vaccination status back in a year ago was 81%. And now, the ones that are unvaccinated, 81% unvaccinated. Now they're 96%. Hold on a minute. Yes. Somebody knocking? I'm sorry, there was somebody just knocking at the door here. So again, you can see that the majority of cases are unvaccinated. And then the hospitalization rate was much higher a year ago at 53%, and now it's down to 13%. So fortunately, the hospitalization rate is much, much less. And so that's an important point as well. And the majority of cases hospitalized are those less than 5 years of age. Next slide. So diagnostic testing. So hopefully everybody has a good handle on what the epidemiology is. Like I said, 7 cases in Michigan. And the people that are the symptoms and signs that you want to really, really be aware of. And so when you have a case that you're suspicious about, what about the diagnostic testing? What test should we do as far as looking up? And so you can right now in your clinic, and what I do as well, there's a test for measles, mumps, rubella where you get antibody testing, and it checks for IgG, which means exposure of unknown time, either exposure to natural infection, exposure to the vaccine, the majority of cases, and you can tell if a person has immunity to measles. And that's an important point to remember because those of us born before 1957 have almost a lifelong immunity because of the natural infection. And then it varies after 1957. So it's always probably a good point to see what the immunity is of people. Or if you suspect that they're, not immune, you can go ahead and give them the measles vaccine. It's a live vaccine, but it's still a very safe vaccine as long as you're not immunosuppressed, meaning, like a person post bone marrow transplant, cancer patient on chemo, or an AIDS patient for that matter. And I'll give you the exceptions to the vaccine. But so the serology you can do to just see if there's immunity is the regular measles, mumps, rubella antibody tests. But to diagnose somebody with active measles, there's an IgM serology test. But if you test people just randomly, then you're going to get a lot of false positives. And the IgM is always the antibody that increases during an acute exposure within the first 6 months. And so you want to be very, very careful of just using this as a test in general, just to check everybody under the sun. Because, like I said, there can be some false positives in that. So you want to be careful how you use the serology. The IgG is the antibody test just to check for immunity. The IgM is more of a diagnostic test to see if somebody that you have in front of you has actual measles. The better test, the more accurate test, the one that has a higher sensitivity specificity is the reverse transcriptase, or not reverse transcriptase, but the RT-PCR test. And that's a test that measures actual for the virus, and it's done either oral pharynx or nasal pharyngeal. And that should be collected. That's the more accurate test as far as testing goes. Next slide. And so the IgM alone poses challenges. There can be cross-reactivity with other causes. So mumps, rubella may cause a cross-reactivity with it, so it's not 100% specific. And then there can be false positive tests, and it can pick up people that may not have measles but may have some other condition. And so it's something that you have to be careful about when you're utilizing it. If it's, if you're not sure if the patient doesn't have any history of traveling somewhere where they might have been exposed, or they're unvaccinated and, you're worried about an exposure with somebody in the local community, then just doing it randomly may be something that you have to be very, very careful about. Next slide. But the RT-PCR test is most commonly used in nasopharyngeal or oropharyngeal swabs, and the urine can be used as well. The ideal time to collect it is 3 days of the rash. So anytime there, or even with the symptoms occurring, the 3 Cs, for instance. But the highest peak as far as viral replication goes is usually during the rash period of time, but it's probably okay to do it even before that. Make sure you know how to collect it and what to do with it. Your health department can give you all the details about it, but you can see that it's got a much better predictability, sensitivity, and specificity of who and who doesn't have measles versus just doing the IgM serology. And the CDC, as well as your public health labs, can do that, can get you the swabs or tell you how to get the appropriate specimens and things like that. That's the important thing to remember. So, testing for measles, again, IgM serology, but the better test is looking at the PCR test, which has the higher sensitivity specificity. So, I hope everybody has that. So, you have the clinical presentation, the signs and symptoms to be aware of, and now you have the testing that we would normally do for measles. Next slide. The treatment. Unfortunately, we don't have a treatment like we do for influenza and for COVID with Paxlovid and things like that. And so there's treatments that have been looked at, and the CDC recommends vitamin A supplementation for hospitalized children. And you can see the different doses. Vitamin A has been actually, the studies that were done in centers and areas of the world where there was vitamin A deficiency. So I want you to be aware of that, because when there's other individuals in this country that happen to be in high political areas that recommend vitamin A as being the actual cure and treatment for measles, you got to be careful about what you're thinking about, because it's not something that can be utilized in everybody, because vitamin A can be very toxic if you give high levels. It can cause liver toxicity and brain toxicity. So it's mainly indicated in people that have had a deficiency or are coming from areas where there's deficiencies of that. And ribavirin has been used as well, but it's very limited as far as the efficacy and the experience. And so in order to really use it, I've not used it. I've not seen any measles yet, but getting somebody that might be more expertise, or looking at somebody where they're severely immunocompromised and you're now worried about a severe outbreak, and maybe using vitamin D as well, or not vitamin D, but ribavirin as well. There's other treatments that have been pushed around that you're going to hear about. One of them is a steroid called bupropion. It's any steroid in a viral infection, you have to be very, very cautious. It's like taking a big gas tank of gasoline and pouring it on a fire. You're going to explode. Steroids at 20 milligrams a day over beyond 2 weeks is immunosuppressive. It's not anti-inflammatory. It's immunosuppressive. And when you have an active viral infection going on, it can be immunosuppressive even earlier because your immune system is really clocked. And so you can cause a minor or a moderate disease to go out of control by giving any kind of steroid. So that is absolutely a contraindication without any data to support it. And another drug that you might hear about is a drug you've heard about, clarithromycin. It's a cousin of azithromycin. It's a macrolide. And the only use that drug may have is if they get a secondary infection like a pneumonia, like I just talked about, or an otitis or something. It would be treating the secondary infection. This is an antibiotic. It has no antiviral activity whatsoever. It may have somewhat of an anti-inflammatory effect, which you have to be careful about, but it has no antiviral. So I want to make this very, very clear as far as treatments go for measles. And there is no substitution, unfortunately, at the present time for a vaccination as far as both pre and post exposure to measles. Next slide. So susceptible contacts, These are ones that, are at high risk to develop measles. And these are ones that may have a serious disease associated with it. And they're your infants aged less than 1 year, your pregnant individuals, and your immunocompromised individuals that are either on chemotherapy, high dose steroids for some anti-inflammatory condition or some condition, autoimmune condition, TNF agents for rheumatoid arthritis. And that those are all ones you have to be careful. And with me, with my HIV patients, I have to be careful about anybody with T cells below 200 because those are all high risk individuals that may not just get the infection, but may get a real serious outbreak of infection. Next slide. So what is the provider's role in outbreak control? Next slide. Identify suspect cases and report them immediately to the local health department. And again, work with the local health department, as far as testing goes to confirm cases, do the appropriate infection control. We'll talk a little bit more about this. Control to prevent further transmission, meaning isolating the patient, making sure they're in an isolated area. It'd be good to have a negative pressure room, but if you don't, which many of us don't, just putting them in a room. But remember, when they get transferred out, that room is still infectious for 2 hours after the patient leaves. And then ensure the staff have immunity to hepatitis or to measles. And then you can do that by obviously doing the antibody test I mentioned, just the IgG antibody testing. And then post-exposure prophylaxis for case controls where you might have somebody exposed that you want to get them on something right away. And then prevention through the MMR vaccine, and then educating. I think the education is extremely important, both for the community, for healthcare providers like we're doing today, even for patients. Next slide. So suspect case identification and reporting, early recognition, case investigation, prompt public health response can really limit the spread. So work with your public health department. I mean, we have Ingham County here that's very that reported a case locally here. And so work with them. They'll be able to give you direction on how to handle it, what to do, etc. And clinical suspicion. Know the presentations. We talked about the presentations. We talked about what symptoms you want to be very careful about, and the pathognomonic Koplik spots. It can be very helpful, as well as the rash for that matter as well. And then patient history. Were they vaccinated? Did they have a travel history where they might have gone somewhere and been exposed and came back and not had any symptoms because it was during the incubation period, and now they have symptoms all of a sudden? And then contact with somebody out of the country that may have measles. Because remember, the R0 is very high. One person infects 18 people. And then contact individuals with similar symptoms. So one person, and if they, been in their house or something, then also contacting the people that they've been exposed to in their house. Next slide. And then back to the symptoms again. Remember, they have coryza, nasal stuffiness, nasal congestion, a cough, and then the rash that occurs first on the face and the neck. That occurs after the symptoms, the high fever, the diarrhea, the coryza. The young infant on the right side has a conjunctivitis. These are signs that are early, and then within 4 days after the signs, or after these early signs, then the rash breaks out. And the rash on the face and neck traveling down to the trunk, on the extremities with the Koplik spots. This is what you want to be very careful about. Next slide. And there again, there's another picture of, just looking at that granular type pattern back there, the back of the throat on the buccal mucosa, where it looks like sand was thrown back there, and they're just granular appearing, and they're white. They can be red or they can be bluish. And so those are pathognomonic for measles. Next slide. This is a differential as far as the rash goes. You can see a whole host of different, infections there. I'm not going to go over each one, but just so you're aware that other conditions can cause a rash as well. But put it all together, put it together with the initial three C's, the rash, and the Koplik spots, and many times you can lessen that differential down pretty effectively. And so this is where you have to be real careful and don't wait for lab confirmation to report it. Get it reported and then have your health department work with you as far as what to do. Get this person in an isolation, probably at home or somewhere where they're isolated during that period of time because of the contagiousness of this disease. Next slide. So the guidelines. Next slide. Okay, so pre-exposure or post-exposure prophylaxis, within that window of exposure to where you can still provide, some type of protection. And there's two types of post-exposure prophylaxis. One is the measles, mumps, rubella vaccine, and that should be given within 3 days or 72 hours of the exposure to that patient. So somebody says, "Oh, I was exposed to so and so, they have measles now, and it was 2 days ago or something." You're within that window to get the vaccine that will be effective in protecting you as far as a post-exposure vaccine. If you've gotten outside of that window, the protection may no longer be there, but at least you'll have something for future exposures, as far as, for measles, but it may not be considered adequate post-exposure prophylaxis if it's beyond that 72-hour window. What about patients that can't get the vaccine? They're immunosuppressed, they're pregnant, their T cells are less than 200. What do you do for them? Well, immunoglobulin, and it needs to be given within 6 days of the initial exposure. And it can be given either IV or intramuscular. And then this can be prioritized for that situation. Next slide. So the vaccination, getting back to the vaccination, it was licensed in 71. 2 doses are 97% effective. 1 dose is 93% effective. And you can see the schedule there, dose 1 versus dose 2. It's given, within a year, years after the first dose is given. If there's an international traveling that's going to occur, they're greater than 6 months of age, then probably they should have a vaccine prior to that, at least one documented dose prior, so they can have some type of immunity. Because remember, the ones that are at serious risk for serious complications are usually less than a year of age. So if they're unvaccinated and they're 6 months and they get exposed to measles, they can have serious complications with that. And then if they're greater than 12 months of age, then they can go with 2 doses. So those, and then for healthcare providers, or other types of high-risk individuals, 2 doses are recommended as far as the measles, mumps, rubella vaccine. Next slide. Contraindications. Who can't not get it? Severe immunocompromised individuals. They have a hematologic malignancy, not one that's in remission, that's no longer active, but one that's active or being currently treated for. Any type of chemotherapy that might suppress the immune system. And the one, don't forget, steroids. Because if they're on steroids, anything above 10 to 20 milligrams a day for greater than 2 months or greater than 2 weeks, rather, then they're considered immunocompromised and they're no longer using the steroids just as an anti-inflammatory. So just remember that. And then if there's CD4 count in my little area with less than 200 would be considered less live vaccine and contraindicated. Any family history of any kind of a congenital immunocompromised, there's some congenital immune deficiency states that you would get a history from. Very, very rare, but it's always important to at least ask the question. And then any severe allergic reaction, if they've had this vaccine before or and they had a bad reaction, then that would be a very, and then finally pregnancy. So those are the contraindications. Those is where you might consider using IVIG, immunoglobulin. So what about the MMR itself? It can cause a self-limited rash. So you may give the MMR and then all of a sudden they have a rash. And now is a rash from if you're giving it post-exposure, then is the rash from the vaccine or is it from the measles itself? And then serology, like the IgM, can't differentiate it. So the only way you can differentiate it, again, is the RT-PCR test looking at nasopharyngeal and oropharyngeal. That's the way you differentiate because occasionally you can get a rash that's very mild, but still can be an outbreak from the measles mumps or from the measles vaccine. Next slide. So further infection control practices, implement appropriate infection control procedures for any suspected case. Make sure you have a medical mask on the patient, and an N95 would be the preferable one because remember, this is transmitted respiratory. So you want to protect anybody from respiratory transmission. And so the N95 is much more protective than just a regular mask that might be available. But any mask is better than nothing, but the N95 is the best. And for healthcare providers, the N95 is what you want to use. And again, a negative pressurized room is ideal, but alternatively, in most clinics, we don't have those, including the one I am in right now, a private room away from susceptible patients with the door closed. And remember, don't use the room for 2 hours after the patient has left. And always alert the facility to the transfer of the patient. And then isolate the patient, they go home, they get isolated. The members of the family, whoever's in the house, wears the N95 masks, and you go through the 4 days of the rash. When the rash starts, and 4 days after is when they're the most infectious. And so that's the ideal area as far as doing infection control practices with known cases of measles. Next slide. And then vaccinations for outbreaks. You want to have evidence. Like I said, I'm testing everybody that comes in my clinic now if they have antibodies to measles. And if they do, that's fine. They gets put in the chart. They have immunity to measles. And you can see they give titers of antibodies greater than 500, and it tells whether it's an adequate response or not. If they don't have any immunity to measles, they get the vaccine. And we have vaccines available here, and we get them right then and there. And so this is where, you want to vaccinate them appropriately. 2 doses are much more immunogenic than 1 dose. But even 1 dose can be, 93% effective in somebody with a normal immune system. And then some children may even require a 3rd dose, depending upon the age that they got their first dose, if it's before 12 years or 12 months of age. Next slide. Pregnancy, again, they have a high risk of complications with miscarriage, preterm delivery. It can't be given during pregnancy, so you now have to rely on the immunoglobulins if they're really you're really worried about an exposure. They're in the same household with somebody that was diagnosed with measles and they were there, exposed to them. They deserve, IVIG or intramuscular immunoglobulin. And so always remember that. Next slide. And then this just gives you a large global measles outbreak from September 23 to February 24. And you can see some of the countries on the right-hand side that have, how many cases they have as far as the numbers and things like that. So, individuals coming from some of those countries, obviously, especially unvaccinated ones, are at high risk for, carrying the virus. And remember, during the first 7 to 21 days, they may have been exposed and be incubating the virus, yet may not have any symptoms until they start getting the 3 Cs and then the fevers and things like that. So say somebody coming from, one of those countries, Kazakhstan or one of those Afghanistan or whatever, not Afghanistan, but Pakistan, and then being at home or being at a friend's house, and then all of a sudden start developing conjunctivitis, congestion, and and definitely a rash afterwards. Those are ones that again are very, very high risk as far as having a measles outbreak, and how you want to distinguish it from just another type viral outbreak. Next slide. And so the summary, it's maintained measles control for since 2000, and early recognition, appropriate diagnostic testing are essential to measles control. Measles immunization gaps in communities, those are the areas you have to be very concerned about. And in Texas, there were little pockets of areas where individuals hadn't been vaccinated, and so you want to be very much aware of those pockets if they're anywhere else. And so, in as far as areas that you might see measles cases or outbreaks, and then we always have to be vigilant for the risk of measles importation from other areas of the world, which I showed you on the previous slide, the number of cases in those areas. Next slide. So that's it. That's the talk. These slides will be available. It's something that, I wanted to give everybody an awareness of. Work with your health department, work with whoever, locally that has the experience. And hopefully things will be under control, and try to get everybody vaccinated that's been unvaccinated or has no evidence of no immunity other than those high-risk individuals I talked about. So with that being said, we're done with 5 minutes left.
Is this
So,
time for questions?
yes,
So I'm interested in finding out about the subacute sclerosing panencephalitis issue, even though it's rare.
yes.
What triggers it to return, and where is it hiding in the meantime?
That's an excellent question, and I have to be real honest with you. I haven't had the time to. Maybe what I can do is uh, get some information and give it to Renee to get back to you, but because I don't know, that's something I thought about when I read it. Because, like I said, it doesn't occur. It can occur right after, but it can wait for 7 to 10 years and then all of a sudden recur, almost like a virus that's hiding or something hiding in there that didn't make sense to me. So I'll have to get more information on that to get to you so it's accurate. But I can tell you that fortunately it's not a common thing, but it can occur. And I remember reading case reports or something where somebody would come in with an unexplained panencephalitis, and they worked them up for every known thing. And then there was that history of possibly measles back years and years ago that was probably the cause of it. But yeah, I apologize, but I'll try to get more information on that.
Thank you. It's fascinating.
Yes, it is very much for me. So for me as well.
We also had a question that came to me directly. It was just, what is the recommendation for those who were vaccinated shortly after the 1962 vaccine became available? I don't know if there's any recommendations from
What I would
previous.
do, yeah, with those not, yeah, the after 1962 or 1957, 1962, check your immunity, do the antibody test to see if you have immunity, and then go from there as far as what you should do after that. Because some individuals may maintain immunity, many lose it, but this way you'll be definite in knowing one way or the other. Let's just say, for instance, that maybe the person couldn't get the blood work done or something, but you considered, that they're going traveling or something high risk. If they had immunity and if you vaccinated them, you would not harm them. You would not cause some kind of a high, like an autoimmune reaction to occur or some kind of a serious problem. I've read that in the literature. So you wouldn't be harming a person from giving them a vaccine if you didn't know their immunity. But I don't know. I always like to, like I said, in my clinic, I'm checking everybody and then I'm immunizing individuals. And I got to say that out of the ones I've tested so far, maybe about 30%, 30 to, yeah, about 30% are show that they have no immunity whatsoever. And so I've been vaccinating them, obviously.
I'm also curious about the population who are non-vaccinators and have these wild conspiracy ideas about vaccinations in general, and especially now with measles. How do you respond to individuals like that who are very much anti-vaccine?
Oh boy, that's $1 million question. If I had the answer to that, I would be really, I don't know. But yeah, there's no good answer to that, unfortunately. I mean, I try to give people as much information and as accurate as I can. It was just like HPV, I was giving talks on human papillomavirus and vaccinating young women, young girls, and that sort. And these parents came to these meetings, and I basically scared them, is what I did. I said, this is not just a virus. This is a virus that causes cancer. And I said, do you want your kids to be exposed, and get cancer, have a high prevalence of cervical cancer or anal cancer? And so I use that as a technique. And I actually it was interesting because I had a lot of parents come up and want the vaccine as well as their kids because they were so scared that they might be somebody that might have it or get exposed at some point that were outside the age limit. But I try to use accurate information, give them the facts, and just, hope that they pick up on that and don't get into the stuff about using clarithromycin or using, cod liver oil that has high doses of vitamin as a cure for measles, because I might as well be a witch doctor and shake my beads, and in that case, I'll be just as good as the person that wants to do that other stuff. So that's the best answer I can give you for that. I just try to tell them there's side effects. There's really serious complications. You can lose your hearing, you can get pneumonia. It's not just a vaccine or a virus that just leaves you. Oh, plus I forgot to say this. I'm glad you brought this up, but it's an immunodeficiency virus. It can cause your immune systems to drop. And so I never studied that very much, and I don't know a lot of background, but it's not like HIV, but it can cause some immunodeficiency to occur. So, you don't want to play with that either. I mean, if that virus damages your immune system long term, that could be serious for you. And I don't think anybody's really looked at it because we haven't had any major outbreaks of measles, but it's not a benign virus by any stretch. Well, I appreciate everybody's questions, and we'll see about what our new talk will be next month.
Thank you very much.
Thank you very much. Thanks for coming.
Thank you. And I thank you for your patience in the beginning. I had to log into my phone to hear the sound. So I will get you the slides and the handout Dr. Gulick provided, as well as the recording. So look out for that hopefully this afternoon, if not tomorrow. So we will, and I'll have your CME claiming information in that email as well.
Oh, okay. This is an answer.
Thank you.
Thank you.
Thank you,
Thank you
Peter.
very
Thank
much.
you, Renee.
Yeah, thank you.